Like you said, this is just going to be our billing update session, but we're going to talk about the RAF score and what RAF means, what HCC means. My name is a little bit different than the last time that I was on here. So we can go ahead and go on to the next slide. All right, so HCC, RAF scores, and corrected claim. Most likely not going to read everything on this page here, but HCC's hierarchical condition category coding and risk adjustment factors. So we see HCC and RAF, but essentially they're just phrases that are going to describe medical codes that are linked to specific clinical diagnoses. They're originally designed to estimate future health costs for patients, and along with demographic factors such as age, gender, insurance companies use HCC coding to assign patients a risk adjustment factor or RAF score. Using algorithms, insurances can use a patient's RAF score to predict costs, and it's helpful in predicting healthcare resource utilization. So what essentially that is summarizing is that, like you said earlier, we're going from fee for service where you bill a claim, you bill a charge, the doctor gets reimbursed from that, and we're going to base payments more off of these categories, more off of these diagnoses and conditions. So it really takes a shift from just performing a service to the quality of service that's actually being performed. We go to the next slide, please. I can't hear you, Kemal, here. Okay, looks like we're having some issues, so one moment. All right, so we do have this next slide here. So this explains the RAF corrected claims. So our care coordination department is a team of nurses that routinely conduct pre and post visit chart audits to identify the missed HCC coding opportunities. Our billing team ensures that corrected claims are submitted with updated diagnosis codes. And then this ensures that patient risk adjustment factor scores are updated in the insurance system to appropriately reflect their risk. We did just end 2022, but I didn't have the numbers available. So we did say that in 2021, over 5,500 of post-visit audits ended up requiring a corrected claim. So what this is saying is we have a whole team of nurses that are going through these different charts, these different dates of service, and they're looking for the opportunities where maybe a diagnosis wasn't quite coded up to par. Not that it wasn't the right diagnosis, not that it wasn't the correct condition, but really we want to be as accurate as possible. I gave a little example of, you could say that you bought a new car, but did you buy a new Tesla? Did you buy a new Hyundai? Did you buy a new Honda? You need to be specific about what you are doing or what you're purchasing. We also have that little graph there that just shows you the trends through the months and through the quarters. So, oops, we're good to go on to the next one. Thank you. All right, so capturing the risk. This is a really great graphic that explains what we're looking at here. So on the first one, you can see that we have our pretend patient, age 68. We have their demographic factors, and they have a couple different diagnoses. So they have diabetic polyneuropathy, they have morbid obesity, and they have congestive heart failure. When you add in those chronic conditions of diabetes, hypertension, and BMI, you would get a risk adjustment factor of 0.427. So each one of these issues is categorized differently. So diabetes is in a different category than obesity, is in a different category than heart issues. So each of these has a metric assigned to it. And so diabetes plus hypertension plus obesity equals a risk adjustment factor of 0.427. However, after we looked at the chart, the same patient, same visit, we took an analysis and we looked at it a little bit harder. We see that the patient has diabetes, but we were more specific. Rather than just saying hypertension, when you have hypertension with polyneuropathy and morbid obesity and congestive heart failure, this actually exponentially grows. So when you add all of these conditions together, maybe one of them in and of itself wouldn't be awful, but together they add up to be a higher risk score. So when we actually correctly and accurately code all of these, we get the risk adjustment factor of 1.325, which is a lot higher than that previous 0.427. If we can go to the next slide here, it'll explain a little bit more what those numbers mean. So here I have an example of a patient and that we reviewed, and the diagnoses, all the HIPAA has been removed. But you can see that originally the provider billed 6 diagnoses on the claim. So we have our Z00.00, our E11.21, E78.2, I10, N40.0, and N18.6. You can see as we go somewhat across the screen that there are the RAF scores affiliated with it. So type 2 diabetes is a RAF score of 0.318. Hypertension, chronic kidney disease of stage 5 is 0.237. So essentially these numbers, while they don't seem like much just in the original, I can spout out any number that I want. This is a predictive model to the insurance that the higher the number, the higher the patient is likely to have medical issues, the higher the cost is going to be, not only for the patient, for the insurance, for the facility. Basically, the risk score is determining how much money is this patient going to cost any sort of system. And what our team is doing is we're really making sure that this risk is appropriately identified. This patient was the same before and after we did our analysis on it. The difference is that when we add in an additional risk, we're appropriately telling the insurance, hey, this is a bigger risk. This patient has more issues than, maybe another provider has presented. And so therefore this patient may be needing more care. For this one, in the original 6 diagnoses, 2 had a RAF score. Other ones were just regular diagnoses. But we also saw that, like I mentioned on the last page, when there are multiple conditions, it can cause compounded issues. So you can have hypertension, you can have kidney disease, but if you have hypertension while you have kidney disease, that's a greater risk. The systems working together or not working together provide that risk score of that 0.237 that we're looking at here. Go to the next slide, please. So how do we optimize this? Teamwork is a huge thing. Obviously, my department is the one that's billing these back out. So the nurses, our care coordination, they're the one who are identifying these based off of the office who's coding these. We all have to work together to submit this. Like Kemal said, the billing companies, we're not just billing these charges out, we're making corrections. And it's not just about the fee for service dollar amount anymore. It's really about the reported quality for the patient. And the insurances are pulling this quality metric based off of the diagnoses that we're billing. So we have to have a solid understanding of HCC and ownership at all levels, from the provider up until the person who's correcting these claims. We need to do training as needed. Really, we need to also start at the beginning of appropriate diagnosis coding at high specificity. So if we recognize that the patient has these compounding problems, we want to make sure we're getting that from the start. Supporting clinical documentation, effective data management, and effective flow management all work together for this. All right, and the importance of optimizing risk score reporting. So all of this, and I've mentioned this a few times now, but all of this comes together really to improve the patient's care and to increase the revenue and increase the staff satisfaction. So this isn't just about if we code higher, we get more money. It's not about the idea of just submitting these claims for a fee for service. When we're able to correctly identify the risk that this patient poses, we're able to provide that care. And through a shared ACO, through an integrated EMR, these providers are able to talk to one another. So the cardiologist can talk to the pulmonologist and the nephrologist, and it really is able to increase that care and that communication. We have an example here of the monthly and yearly primary care population-based payment. So rather than that fee for service, that 70 whatever dollars that we get for the office visit, we now see that the insurances are going to share savings. So they present the fact that if you can share or if you can save so much money by providing better care, then that's what the point of the ACO in this is, that they're going to share that savings. So when the risk score is under 1.2, it's $28 per member, times 300 would be 8,400. But when the risk score is higher, you can see we went from $28 to $45. So just by making that one little shift, maybe identifying that one diagnosis, maybe that it's a obesity diagnosis or a mental health diagnosis, anything that has that RAF score, we shifted our monthly population-based payment from $28 to $45. And that's a huge increase, which you can see adds up in the yearly rate. All right, that was it for me.
All right. So, Katie, so what we shared is what we know, like our core business, revenue cycle management, right? So, and main part of this is the physician compensation. So, physician compensation is no longer like it was in 1967. Right, so I use and every time I have some old days, I use the 1967 reference. It helps me at least. So in the old days, physicians were not on the cost side of the equation, so they didn't even know what patient costs, or do they even care, because that was not how they were paid. So how we are paid from the compensation standpoint for physicians is a lot to do with the value that we actually generate, value-based contracts that we work with. So then this standard fee-for-service agreements are no longer effective. They're inefficient because you just go by like number of patients you see, but how you see them is important. What you do with the patient is important. And in some cases, patient doesn't actually have to really just come to the physician and tell everything about what's going on with them. Sometimes we really need to bring up issues that they may be not sharing with us, and that's part of the value. Like, this is how we are going to be able to have an effective way of being proactive. So, like, everyone can be proactive, but there has to be an efficiency in that proactiveness. So if I'm not efficient, if the outcome is not going to change, you can be proactive. So this means you have to engage with the patients. And engaging patients, I just want to give you an example, and you are on the RCM side of it. So as you know, I do daily case conferences with our ACO team and also our bariatric team. So with the ACO team, we see issues with patients maybe not sharing. Like someone who may have hemorrhoid, they're not telling their doctors that they have bleeding, and the doctor is not making certain orders based on that. Or an elderly who's shy maybe to tell the doctor that they have urine leakage, and then they're not able to, if we are not actually kind of going into the details with the patients, we are not able to find these issues ahead of time. And these are not only not just from the cost standpoint, but from the quality standpoint, it's extremely important. So we know that we have a lot of elderlies around us, and if they're not able to get this help, it's gonna actually it's gonna make everyone's life a little bit more difficult. Now, the risk score is a really good way of communicating our issues, our findings with the insurance company, so that way, when we do our job very well, then we can actually demand better compensation. And this is the model that United Medical ACO is focusing on. Now, the big difference in the old days, we were just focusing on how much we are collecting for each of our clients. But today, that's not enough, because that is now tied into how our clients are billing. Do they capturing all the diagnoses? Do they go to the highest specificity of the diagnosis? Do they see the patients frequently? So the patient needs to be seen. Most Medicare patients, they need to have, if they don't have any issues, they should be seen twice a year. and this is based on Medicare guidelines. So do they get their routine checkups? So this is a different ballgame now. So in the old days where we used to be just a medical billing and the EMR company, today we are a clinically integrated group, and our revenue cycle management adopted the changes that we have, and you guys are a big part of loss opportunities. Like your team, you guys are able to work with our nurses and care coordinators to help our physicians to capture what they have missed. And because today we cannot miss these incentives anymore, because they are no longer incentives. I always say this and people don't understand what I mean by this. Incentive is something that you get extra, but if this becomes part of your compensation, that's part of your total payment. So incentive is you get your total payment and then you get an incentive. That's different. But today's world, value-based contracts are part of our main compensation. So
like the medical Maslow's hierarchy of needs. Once you meet the base requirements, then you're going to be building on that. And it's really interesting too, because the diagnoses were the foundation for it. So we've always used diagnoses to build the claims, but now we're building quite on top of that. So it's a really neat foundation and kind of a pyramid to look at in that way.
Absolutely, absolutely. Well, I'm hoping that these sessions are going to help our employees who actually just join us, and we are actually using these for our trainings as well. Not like the main training resource, but as a support for our new hires. And in some cases, our well-established employees, they do need to hear these in a different way in time to time. So then it actually makes their understandings much better and much more clear. Well, Katie, it's always good to have you, and thank you for joining us today.
Thanks for having me. Have a great day.
Bye-bye.